Recording stopped.
Can you all hear me?
Yes, madam.
Can you see the presentation?
Yes, madam.
Okay. Good afternoon, you all. So I'm Shishma
Recording
Fonseca.
in progress.
I'm neonatologist from Anuradhapura. So the topic that I'm going to discuss with you is managing the preterm infant at birth. I hope you have gone through the normal resuscitation protocol and how to resuscitate a term baby. During this lecture, what we are going to discuss is how to manage a preterm baby, which is slightly different from a term baby. Okay, so this topic, it's very important to identify few problems. I hope we have already discussed this problem, but we are going to further elaborate it because these are the key important factors in managing preterm. So if you mismanage a preterm, in short-term basis, you will see that this preterm baby will be hypothermic and hypoglycemic, and same time, if you have given oxygen unnecessarily, you are exposing this baby for a hyperoxic situation. So if you do those things, then baby will end up in long-term complications. So what are the common long-term complications which has severe morbidity and mortality? One thing is intraventricular hemorrhage, that is the hemorrhage in the brain. And then bronchopulmonary dysplasia, in simple term, it is the chronic lung disease element occurred in preterm babies. Retinopathy of prematurity, which is again the manifestation secondary to unnecessary exposure to oxygen. Okay, so the preterm babies, there are three main areas we are going to highlight in this. Which babies to worry about? So preterm itself is a worry, but out of this preterm, there are certain categories you have to particularly concern about. So that is, we are going to highlight in next slide. Then what are the differences from term to preterm, and how does this alter our approach? Okay, which babies you worried about? So if you take about the preterm babies, we say preterm, any baby born less than 37 weeks. We know the pregnancy can extend even up to 42 weeks. So between 37 to 42, we call term baby. Then there are certain categories 34 to 36. We are not highly bothered about it because their behavior almost similar to term babies. Then there's another category, 31 to 33 weeks. So they might behave as term babies, or they might behave as the babies who are younger than that age. So that is 30 weeks and below. So 30 weeks and below, they are definitely different. So this 31 to 33 weeks might behave as 30 weeks or below. So this is the category you have to be careful and you have to give your full attention to get their maximum better outcome. So what are the differences? We already discussed these points during the previous lectures. They are more vulnerable to get cold. Even the term baby is vulnerable to get cold. Why? Now from the mother's uterus, they are coming out to a very cold environment. They are naked, they are wet. And when you compare about the thermoneutral mechanism, compared to term, the preterm has no thermal control mechanisms, though they are more vulnerable. And they have more fragile lungs. Why? They don't have this surfactant if they born preterm less than 34 weeks. So their lungs are not mature enough to expand and to adapt for the normal ventilation. They don't breathe effectively because they are the intercostal muscles and their breathing mechanism has not developed. So their breathing mechanism may be very poor. So they have very few reserves because we all know the reserves usually they store during the third trimester. So they born early, so they don't have these reserves to face this. When the pulse oximetry often indicated, why we are saying so is because the color may not be ideal to assess the baby's condition. Okay, so when you talk about preterm, it's very important to discuss about the antenatal period. So if you prepare the baby prior to delivery to get the optimal outcome, that is the best way that you can have a very good preterm baby or the very good baby you can discharge from your PBU. So you might be thinking why as a house officer this is important for you, because you might be working in a antenatal ward, maybe in a gynecology ward. So the preterm, the mother with this preterm pregnancy might be ended up in delivery in your ward accidentally, or you might be the first person to contact with this mother. Then you can address this problem and then you can sort out this problem. Then you can hand over a stable preterm baby to us for further management. So it is important about the gestational age. We discussed this point. So when the maturity is less, the outcome is generally the poor. The complications are more with lower the gestational age. Again, the multiple pregnancies has more complications than the single pregnancies. For example, they can have feto-maternal they can have the twin-to-twin transfusions. So it is important. So there may be growth restrictions. So it is important to know whether it's a single pregnancy or multiple pregnancy. Then antenatal steroids. So the antenatal steroids has a lot of benefits, not only for the IVH. You can see the IVH, the intraventricular hemorrhage, reduced by 46%. So that is a huge number, isn't it? So the IVH might determine the whole the neurodevelopmental outcome of this baby. So if you can time this antenatal steroid, if mother is coming for a preterm delivery, then we can give the antenatal steroid at the appropriate time. So there are two preparations, dexamethasone and betamethasone, depending on the drug where you available in the unit. So then the other drug is the magnesium sulfate. So why the magnesium sulfate? So the research has found it's a very good drug and which is practicing in our country as well. So it will, so we give for the preterm births who are less than 32 weeks of gestation. What is the importance of it? It will improve the neurodevelopmental outcome of these babies. Then if mother comes with the premature rupture of membrane, then that's a route for introducing infection. So you can start antibiotics to the mother. By that, you can prevent the infection or the chorioamnitis or the pregnancy won't be further complicating. So by controlling the infection, you might be delaying or you may be extending the pregnancy further by avoiding preterm delivery. So it is important to address these points as a house officer. Don't wait until the mother delivers. When you encounter anticipating this kind of preterm delivery, please think about steroids. Please think about other associated risk factors, magnesium sulfate, whether this mother needs antibiotics. Okay, so what is the ideal place for delivery? You have to think about regionalization of care. Why? Lesser odds of mortality. What does it mean? So if you deliver the baby in a well-equipped center where you can manage an extreme preterm baby with adequate facilities, then the outcome will be good. So the mortality will be less. So the ideal way, if the center is not having the incubator care, or it could be the inadequate facilities at the center, or it could be the lack of space at that particular point, then you have to think about in utero transfer. So why the in utero transfer? So if you deliver the baby at your unit, and if you are transferring this preterm neonate after the birth, that means the first 48 hours life, it associated with increased risk of severe IVH. So then that itself says that baby, the ideal transfer should be in utero. Okay. So according to antenatal counseling, so now this is a stressful situation. So ideally this should be done by the most senior person, either neonatologist or a pediatrician. If they are not available, then it could be the senior house officer from the PBU staff, or it could be if no one is available, at least they as a house officer, you can give some idea what's going to happen to this mother, because she may be having feelings of guilty, fear, anger, suffering, and sadness, because this is totally unexpected situation. So they might, if it's a extreme preterm like 22, 24 weeks, they might not, if you tell about the consequences, the long-term complications, possible complications, they might think about the rejection. So we can think about how to proceed after the delivery. So it is very important to counsel the parents, the both mother and father, to face this situation. This is the ideal setup, what is happening in the other country, and that is what we are practicing in our country as well. So don't neglect this part. If you encounter, please inform the NICU staff to come and speak to this mother and inform about and discuss about their wishes and plans. Okay, so then at delivery, so what you are going to do? So depending on the gestation, you might think about whether you are going to do a comfort care or active resuscitation. What does it mean? Because if baby is extremely preterm and the age, the baby's weight is not compatible with survival, then we might think about comfort care. So we are not giving the extensive resuscitation. So from certain gestation point onward, we do active resuscitation. That is very important. That's why the antenatal counseling is important. That's why the mother and father should aware what is going to be happen for their baby. So this is, I have summarized according to the guideline of the positional paper published in Sri Lanka College of Pediatrician for the resuscitation. So any babies who are less than 24 weeks and less than 500 grams, we give only comfort care. But if they are more than 26 weeks or above with more weight 600, then more than 600, we'll give full resuscitation. That means you manage airway, you give the chest compression. So, but babies between 22 to 26 weeks, weight is 500 to 600. Then it is airway and ventilatory support without cardiac massage and adrenaline. So this is the guideline what we have published in Sri Lanka at the moment. So then assistance versus resuscitation. What does it mean? The most preterm babies need help with transition to air breathing, not resuscitation. So you might think the preterm baby always needs resuscitation. No, they only need the adaptation for this new life. So it may be only the assistance, not always the resuscitation. So it is very important to carefully assess the baby to see whether this baby needs only assistance or whether the baby needs a resuscitation, and you give a gentle support to this tiny fellow. So it is always kill care at birth. Now this is a preterm baby. So ideally the neonatologist or pediatrician, senior medical officer with experience, and ideally it should be a NICU, neonatal intensive care unit nurse, and the anticipatory preparation. So we can prepare prior to delivery, and we can organize a team. We can allocate a person for the airway. Usually the airway person is the most competent person to manage the airway. Might need an intubation. You need to give the inflation and ventilation breath. So the most skilled person usually take over the airway, and then we can allocate a person for the chest compression if needed, somebody for vascular access, and allocate a nurse for drug preparation. It is important to organize your team prior to delivery. Then speak to the obstetric team and always update them what's happening, and we are ready. So this is the situation. So then they also know. So it's important to keep a good communication with the other team. Always call for additional help. I hope this point we highlighted in the previous lectures as well. You have to prepare your resuscitation kit. You have to prepare everything prior to the delivery, and you check your equipment, your environment situation, control the temperatures to minimize to keep the temperature at least 26 or above. And make sure to inform the neonatal intensive care unit and the transport team if available why this preterm baby ultimately ended up in neonatal intensive care unit. So they have to switch on their incubator, and they have to ready with a warm, pre-warm incubator to take over this baby. So if you haven't informed, they don't know that. So there might not be an incubator even to take over this baby. So it is important to inform the NICU that you are going to, that ideally this should be happen when the mother admitted to your ward. So as a house officer, so please inform, please discuss with your colleagues, the obgyn and obs colleagues, and then inform the NICU that we got a mother with pending preterm delivery. She is 26 or 27 weeks, whatever the gestation, and the estimated weight is this, and these are the risk factors. So she might be delivering within next 48 hours, and we are going to give these antenatal steroids, and if she's going to deliver, then we give magnesium sulfate, and then so we need to reserve a incubator and the ventilator for this baby if she delivers. So that is the message we are expecting from a house officer to the NICU. Okay, so this is another important concept. Always encourage these things, because now this is practicing in our country as well, which has a very great value for babies' outcome, for the morbidity as well as the mortality. Cord clamping. So who are the babies who need cord clamping? Babies who doesn't need resuscitation. So baby who were born with a very compromised situation, we all know we cannot wait for cord clamping. But if this baby is stable, even for a preterm baby, it is very important to give the cord clamping. So how long you're going to wait? At least 1 minute. So it could be 1 to 3 minutes. What we are going to do is we allow placental transfusion. So During this time, it's important to keep a baby warm, so you can cover the baby with the pre-warm towel, and then you allow the cord clamping, and make sure that you have to observe the baby's color tone during this time as well, because it's a preterm baby. So by giving this delayed cord clamping, you are allowing at least about 80 ml. At 1 minute, you allow at least about 80 ml blood to the baby. So if you delay it to 30 minutes, that will be about 100 ml. So now you can see, so by doing this simple maneuver, how much you are going to achieve for the baby's outcome. So as I mentioned before, the delayed cord clamping has early benefits and late benefits. So it will give hemodynamic stability, and you need less inotropes. Now the blood pressures are stable because you have good volume of blood which received from this placental transfusion, and then less need for blood transfusion, which is very obvious. And later they have found the baby's motor functions are improved at 18 to 22 months of age if you do this delayed cord clamping. So the baby, I think this topic we already discussed, that is hypothermia. So how are you going to prevent hypothermia? We are going to fix this ambient temperature in delivery room about 26 or above, and you switch on your radiant warmer prior to delivery. Not after the delivery. It should be prior to delivery, and it should be warm by the time baby arrives under this warmer. And you have to have pre-warm towels and plastic bags. This is something which we haven't used in term babies, isn't it? We usually say any baby who is less than 32 weeks, less than 1.2, you can use this plastic bag, and you can use a hat to cover the baby's head because it has larger surface area, and which is lack of hair, so which is a good area to lose more and more heat from the baby. So you pre-warm the baby's incubator. That's why I told you, you have to inform the transport team to switch on the transport incubator, switch on the baby's incubator in the NICU. So they pre-warm it prior to arrival. And there's another thing called humidity, which also we discussed on previous lectures. So humidity at least about 85%. This is something we are talking about this preterm baby. Okay, so this is the summary of what is happening in the hypothermia. So then the temperature, you can see the severe hypothermia is less than 32, and the cold stress between 36 to 36.5. Even drop of 1 degree Celsius of temperature, the baby's oxygen consumption and metabolic rate will increases by 10%, because baby is trying to, this poor weak fellow is trying to develop their, make the heat by using the energy, which should not happen. We should provide that warm environment for that baby. So it is very important to keep the baby warm by providing these measures. So this is how we use this plastic bag. So for this plastic bag, it's not a sterile one, it's a clean one. We use the bag which we used in the supermarket, so that you can cover the baby bag, cover with that bag. There are pre-made bags as well, but in our country we use that the bags which we use for, to get the vegetables, fruits in the supermarket. So you can cover the baby's body, and you can cover the head with a cap. So if you want to do any procedure, you can make holes through the bag, and then you can even put the UVC, the umbilical lines, through that. So it is important to put the baby into this bag and keep this bag and the baby under the warm clothes, and so that bag itself acting as it will prevent the further heat loss from the baby. So at the beginning I mentioned that it may be difficult to assess the baby's the color because it's a preterm baby. the skin may be very dark, maybe skin bruises, so the color may be not a very accurate in these babies for assessment. So it is important to use the pulse oximeter. Always fix it to the right wrist or a hand. That is the preductal saturation. So the very important message what we are going to discuss is the hyperoxia, which is very detrimental to many organs at cellular and functional level. So always avoid hyperoxia. So the oxygenation level, so this is the study result which they have found how the normal saturations behave in a baby who doesn't need the resuscitation. So at 2 minutes, you can say the baby's saturation is 60%. So that means if the baby's saturation is 60% at 2 minutes, we are not going to do anything. So usually this chart is available at the resuscitation with the resuscitator. So you can see it until you get familiar with that. So baby takes 10 minutes to reach the saturation of 90%. So you can wait until then. So don't be panic and start oxygen. Don't give unnecessarily oxygen. This is the normal pattern how they behave. Because in utero, their normal saturation is about 60%. So from that environment, they adapt for the outer environment and reaching the 90% saturation at 10 minutes. Okay, so don't add oxygen if saturation is above 95. So the 100% oxygen is which actually has very bad effects. So you don't need oxygen to start resuscitation, but preterm babies might need some amount of oxygen. So it says the oxygen increases the work of breathing by 45% and oxygen consumption by 25% and carbon dioxide production by 17%. So this creates, if you give more and more oxygen, it creates more and more free radicals like peroxide, hydroxide. So these free radicals can damage a lot of tissues. What are the vulnerable tissues? They damage, they oxidize with the free fatty acids and they interact with proteins, DNA. So it affects, you can see the impact of it. So at lung level and at the brain, so it has a lot of very bad effects by this free radical mediated damage. So it reduces the cerebral blood flow as well. So this is the lung. As I mentioned before, lung is very fragile and overinflation causes damage and which leading to inflammation and long-term morbidity. So unfortunately, this I cannot run this video, but what it says is the normal breathing, these alveoli will, it's not over distended and it's very smooth with inflation and the inhalation and exhalation, but in the mechanical ventilation, we are artificially giving excessive pressures and it will damage the lung tissue. So this lung inflation, the baby is now, if the baby is breathing, then so what you are going to do is you are going to apply some pressure, so which will facilitate the baby's breathing. So what is the pressure you are going to give? It's called PEEP, which is important for lung recruitment. How can you give this PEEP? So now I already mentioned that now our preterm baby is breathing. So this is the equipment called neopop. So you can set the pressure. So this pressure ideally for a preterm baby, you can give 5 to 8 centimeter water. So you can deliver that pressure and you can see that the pressure what you are delivering on this interface. So you are not giving unnecessary high pressures. So in the previous lecture we mentioned if you give it through the ambu bag, so when you give it, you cannot ideally measure the what is the exact pressure you are delivering. But here, when you're giving it through the neopop, you can give that PEEP, the pressure, and you can see how much you are giving. So if baby's breathing is not adequate, so in addition to this PEEP, you might need to give some the ventilation breaths as well, so that it's about 20 to 25 centimeters. So you give PEEP, you set the PEEP at 5, about 5 to 8, and then you give the other inflation breaths about 20 to 25 centimeter water. So by giving through this NeoPuff, you will provide a safe pressure level. You are not delivering unnecessarily high pressures, which will cause more damage to the baby. So these two X-rays will show you when you give a PEEP and when you are not giving the PEEP, what will happen. If you give PEEP about 5 is not very high. So when you give 5, you can get good inflation. The lung expansion is more compared to no PEEP. So that's why very important to start a PEEP pressure at the beginning. So once the lungs are inflated, we already mentioned how to inflate the lung, isn't it? So once the lung is inflated, then baby need only the ventilatory breath. That is about 30 breaths per minute. So how do you know how you are giving the adequate ventilatory breath? So if you give too much of pressure, then you can see the chest is excessively moving. We don't want unnecessary excessive chest movement. It is the normal breathing what we are going to see. And so the other important marker is the baby's heart rate. So keep heart rate above 100. Usually, when you give the baby breathing support, if the baby has initial bradycardia, the breathing support itself pick up the heart rate. So if the heart rate is maintaining above 100, you know that you are giving adequate ventilatory support to the baby. Okay, so the labor room or the theater, from that place to an ICU, you transport the baby ideally in a transport incubator. How do you going to support the baby's breathing with NeoPuff? This is the ideal setup what should happen, and this is available in most centers. And this is how you deliver the CPAP. You set the pressure, then the baby is getting the PEEP continuously, so then the lungs expansion will be better. So then I'll quickly move to this preterm and surfactant therapy. Most babies who are less than 32 weeks require intubation within first 24 hours. So if what we say is, if baby required intubation, that means this is the baby born less than 34 weeks. So most probably the baby having surfactant deficient lung disease. Then we give the surfactant also through the ET tube. So the surfactant is a substance will keep the alveoli expanded. So if you give the surfactant at the appropriate time, it will prevent the alveoli collapse. So it will reduce the surface tension of the alveolar wall, and by that it improves the lung compliance. This slide, of course, we can skip, but if you are interested, when you are ventilating a baby, we are trying to avoid the pressure trauma, the barotrauma, and if you give high pressures, baby can have pneumothorax, that is air leaks. So it is important to use the appropriate minimum pressures for the baby, and same time avoid hyperoxia, because we already discussed what are the disadvantage of using hyperoxia, and then avoid extremes of carbon dioxide. So both are not good. Even hypocapnia has very bad effect on the brain. So please avoid the fluctuations, the extreme hypercarbia or hypocarbia. So if you use these measures, the points what we discussed so far, then we can avoid using this postnatal steroids, because it has bad effects on the neurodevelopmental outcome. This is something we all do for the babies, that is vitamin K for all newborn babies within first 6 hours after birth. So we usually give at the time of birth. This is something which will be available in near future in our country as well. That is caffeine that we give for apnea of prematurity. So that study shows that if you use this drug called caffeine in the first 10 days, which reduces the incidence of cerebral palsy and cognitive impairment, which was checked at the 18 to 21 months in a low birth weight baby. So it's a very important drug which is available in intravenous preparation and oral preparation, and it will be available in near future. So it is important to regular screening and for the sepsis and minimize infection, because preterm babies, they don't have the normal good immunity. They are anyway, newborns are vulnerable, preterms are more vulnerable. So you always wash your hands before you enter the NICU, before the procedures, and minimal handling. You restrict the visitors. So I hope you're familiar with these pictures. What are the sites of hands where you can get more contamination when you don't do the proper hand washing. I think those are few areas which we covered on previous lectures, so I'm going to skip that. But nutrition is very important. Always encourage exclusive breastfeeding and support for the feeding methods. I think feeding method also we discussed, so I will skip this slide. And kangaroo mother care, again we discussed. So this graph itself says, if you give the kangaroo care, how stable is the temperature is compared to if you not give the kangaroo care. So developmental care, I think this will be discussed in further lecture, so I'm going to skip this part. So as a parent also, they have a responsibility about their babies. So they have a responsibility to present during the ward round to get idea and what is happening to their baby, because we are treating for their baby. So that is their right to know what is happening. So always they can speak to doctors and nurses to get the update and understand from their level what is the illness and how it is progressing now, and familiar with what are the medicine baby is on, because some of the medications baby might need to continue even after discharge, for example, vitamins. And depending on the clinical condition, there are some other medication we might need to give. So it is important to update parents. So it is important if you update it properly, regularly, then by the time of discharge, then they know what is happening and they are well prepared for the discharge. And always engage parents in routine care. They can engage in nappy changing. So by that, they will, that is, I think the parents are the most important partners for babies handling, not the nurses, not the doctors, though we do the most duty. So always try to engage parents in baby care and understand how to provide how to comfort care and diaper changing, clothing, and give the milk when possible. Okay, these are a few areas in the hospital. You have to be aware that this kind of units are available in the hospital to get the help. Mother-baby unit, when the baby is prior to discharge, usually we keep the mother and baby together. Preterm babies, or the babies who need prolonged NICU care before discharge, we keep the baby in those units and check whether they are ready to discharge. So the education and their anxiety concerns, those things can be addressed in these units. Lactation Management Center, it's very important to give the feeding supports and how to give the breastfeeding, how to give a cup feeding, those things will be addressed in Lactation Management Centers. And kangaroo mother care, this is very important concept which we discussed. So these things are available in each and every hospital. it might not be in a very large scale in each and every hospital, but these things are available. Please utilize them. So before discharge, ideally you should have a family meeting for parent education. So the participant should be the consultant and senior medical officer, senior nurse, lactation management nurse. You can see the lactation. So lactation management.
Rohini, you are muted. Jitma, you are muted. Jitma, you are muted.
Recording stopped.
Okay.
Madam, you're on lunch break then?
Okay, so there is one question. That is, what is the age cutoff to be used in chart shown previously related to preterm time of birth? Appropriate oxygen saturation percentage. I don't understand what does it mean. Can you further elaborate your question?
Recording in progress.
And Yes. And there's one question regarding the comfort care. So the comfort care, there we are not going to do the active resuscitation, but you keep the baby comfortable. That depends on the baby's condition as well. So I think that is beyond your level. Usually the NICU people intervene. So if baby assessment, so I already mentioned about the resuscitation cutoff ages and weight. And if the baby is beyond that level, so sometimes we might need to take the baby to the PBU for comfort care. If not, it could be either labor room or theater, depending on the mother's wish. We provide the baby to the mothers for the comfort. We are not actively resuscitating. So I think absence of the questions, I will conclude my much for your participation, and you will be having your lunch break now. Thank you.